Well, welcome to another episode of the Confidence in Conflict podcast, your destination for learning how to prevent and better manage conflict in both your professional and personal lives. My name is Alan Oelschlaeger. Before we get into my discussion about the prevalence of violence in the healthcare industry with Joel Lashley, who's the author of a book called Confidence in Conflict for Healthcare Professionals, I want to talk just a bit about an NPR show that I heard a few nights ago. This was a hidden brain show hosted by Shankar Vendatam. You might have heard it before, where he interviews a guy named Dr. Keltner, who's a psychologist at DC Berkeley and the author of the book, The Power Paradox. Now, if you know anything about Vistelar, you know that we emphasize the importance of empathy in managing conflict. And the main point of this interview is that people who become powerful within a team are those that demonstrate the greatest empathy, right? The author references dozens of research studies that show this, that he's accumulated over the years. Some he's done himself and some he's read from others. Well, it's not a big surprise, right? Empathy is seeing the world through other people's eyes. So you'd expect that people who demonstrate greater empathy would rise in social power. Not a big surprise. But you might know that the human brain has these mirror neurons that fire off, when emotional or physical pain in others is experienced, which actually causes people to experience at some level what the other person is experiencing, right? And that's empathy. And they've known about these mirror neurons for a while. They can measure them on an MRI test. I mean, it's pretty cool, but these little mirror neurons, they fire off. And that's what causes people to feel emotional empathy for folks. Well, as I'm sure you've experienced, some people's mirror neurons fire more than others, right? Right? In other words, some people are actually more naturally empathetic, and we've all had that experience. So one of the things we teach at Vistelar is how to show empathy, right, to prevent and better manage conflict, even when these mirror neurons aren't firing. And that's common when you're interacting with people who don't know you, right, or you don't know them. And the norm is to feel like, well, I'm not going to be terribly empathetic in situation. I don't know the person, right? I'm a contact professional. I might be meeting that person for the first time. And so sometimes that empathy is a little hard to come by. So here's what's interesting, right? It turns out that while demonstrating empathy leads to power, according to this researcher, gaining power actually causes these mirror neurons to fire off less. So yeah, power actually leads people to becoming less empathetic, right? Causes people to lose the capacity to see the world through the eyes of others, at least according to this one researcher. So how interesting is that? Again, it's not a surprise that empathy, which leads to asking good questions and better listening and paying attention to others and all that, that results in people gaining power. Not a big surprise. But once you feel powerful, it was a bit of a surprise to me that people actually lose the capacity to know what others are thinking and feeling, right? Those mirror neurons actually just don't fire as much. So, for example, in one study, the more powerful people feel, the more they lose the ability to actually read the emotions in people's facial expressions. Again, MRI studies actually show this, right? As people become more powerful, the mirror neurons actually become less active. Well, this research really important to Vistelar in that we primarily train contact professionals who have positions of authority and power. For example, police officers, healthcare professionals, teachers, child welfare workers, like Dan Garris, who I interviewed in the last episode, security guards, those kind of folks. And this research suggests that all these people possibly were attracted to these jobs, were hired, initially performed well in managing conflict because they were empathetic. But then possibly over time, as they feel more powerful, their empathy decreases and they become less capable of effectively managing conflict. So as Shankar says in the interview, although we often think that powerful people are bad people, who rose to the top, maybe what's actually going on is that good people rise to the top and power makes them bad. Well, early in my career, I remember discussions with my colleagues. We'd sit around at lunch and we'd question how the senior management at the company, how they ever got their jobs. Because at some point we said they all needed to have our jobs and we couldn't imagine them doing our jobs very well. So maybe what was happening is they did do our jobs well because of their empathy and their listening and ability to build a team and whatever. But then they got promoted and their capacity to empathize diminished. So maybe the British historian Lord Acton was correct when he said power corrupts and absolute power corrupts absolutely. Well, the interview ends with examples of how some leaders are able to overcome the paradox of power, which again, the title of this guy's book. And the example that was used was Abraham Lincoln, right? As historians tell us, Lincoln tried to treat everyone with dignity, showed respect to the warring sides, right? And that, I think he's kind of known for that. I'm not much of an historian, but that's what I understand. And as you may know, that's really Vistelar's core principle of conflict management. Treat people with dignity by showing them respect. So the good news is that we deal with contact professionals every day who figured this out, either on their own or as a result of our training and are brilliant at communicating with others. Anyway, I thought this interview was quite interesting. I think you would also. It certainly tells me that what we do here at Vistelar is really important work. Anyway, on to the interview. So Joel Lashley has been working with Vistelar for years. I think you'll find his insights into healthcare violence very interesting. The full title of his book really says it all: Conflict Management for Healthcare Professionals, Creating an Environment of Care that are Incompatible with Violence. So here you go. So I'm here today with Joel Lashley. Welcome, Joel.
Morning, Al.
So if you could just give everybody just a quick update on who you are and your background, and then we can get into it.
Okay. Well, as you know, Al, I worked most of my professional life, the last 25 years or more, in healthcare, mostly as a responder to conflict and violence and complaints and other issues in hospitals.
Yep. And as you know, we I think one of your cooler things is you wrote a book about this back, what was that, about 3 years ago? I remember I helped you.
Yeah. I wrote a book, Confidence and Conflict in Healthcare. And the notion was that we could make clinical environments less compatible with conflict. And that was the idea behind it.
And as you know, it's gotten quite a reaction by folks in healthcare. And I remember you told me at the time, and I've probably heard it, I don't know, probably 100 times since then, that healthcare is one of the more violent professions, maybe the most unsafe profession in the country.
Yeah, for a non-fatal assault, and of course there are fatal assaults on occasion, but where there's aggressive consumers, that would be patients and sometimes families and visitors, assaults on nurses are higher than and healthcare workers in general, than just about any other profession. And it's not just an American problem. That's true all around the world.
Yeah. And it certainly gets the news a lot now. I don't know if people that pay attention, it just seems to come up a bunch about what's going on in healthcare. And just, and I think there's a higher level of aggression than there was even just a few years ago. But Joel, you're the expert at it. So what are we going to do today? I know you got a story to tell and a specific topic we want to cover.
Well, yeah, I want to talk about how, the relationship, the position between the patient and provider can be a difficult one. And understanding that instead of denying it is something that's important. When most people went into healthcare, they probably didn't think that, I'm going to deal with aggressive people more than if I'd gone into another profession. And they usually find out as an afterthought, which has always been kind of interesting to me. I think maybe now people are starting to realize that they're making a career choice that's going to involve a lot of physical and emotional and sometimes challenging work, not just with what they need to know, and what they need to deliver, but how to deliver it in a way that keeps them safe and affects their patient outcomes.
Yep. Well, we call these folks contact professionals, and there's people in a lot of different industries that have that role, but it's a tough role. You have to do your duty of your job in healthcare. It's, blood pressures and IVs and, whatever, but you also have to make sure the patient is feeling like you care and there's some empathy there, and they think you're listening. And then you got to worry about your personal safety for all the reasons we just talked about. And then what's changed in the last few years, the camera's always on. So no matter what you're doing, there's probably somebody recording it.
Yeah. And somebody recording it and somebody judging it.
Yep. Yeah. So tell me the story. So what's, I know
okay.
you had.
Well, I mentioned a story a few years back where I needed to do a mediation between a family and some providers. And the issue was, healthcare is a high stakes profession. we're not selling cars and fixing basements. We're working in people's lives and their futures. And so everyone that walks through the door has a set of problems, relationship problems, financial problems, health problems, all mixed in with, their pain, their fear, their illness, their recovery. On the other hand, the provider, we may tend to discount their stress. There's a nursing shortage. There has been for a number of years. It's difficult to find and retain good nurses and other healthcare providers. So that's always a challenge on top of the long hours, weekends and holidays, working nights, the stress at home that's involved with their profession.
Yep.
So everyone in that environment is under stress, really.
Well, I think everybody's had this experience, right? I mean, as you know, I had a little health issue a couple of years ago and spent some time dealing with the healthcare system. And I mean, it's real. And then, we've all had family members that dealt with it. I know you had a little incident a while back. So it's, it's scary, right? I mean, you're in there with a lot of different things going on and it's easy for conflict to raise its head and for things to get a lot out of control.
Yeah. I've been a consumer, for longer than I've been, working in the healthcare profession. And, I've been in those high stakes situations, family members, children that had chronic health conditions, painful health conditions, long-term health conditions, deaths in the family, my own health crises, probably more than most people have by this point in my life. So, I've spent a lot of those long nights sleeping on a hospital bed, hospital room floor. I've been that person in a critical care unit that when the nurse looked you in the eye, you knew they were saying visiting hours don't apply to you. So I know what it's like to be on both ends of the schedule. Yep.
Well, and as you describe yourself, right, you're a little bit of a healthcare violence nerd. That's a result of all that experience. But anyway, so back to the story. So what happened here and what?
Well, what I like about this story is it kind of solidified some of the things that I'd learned over the years. And by this point, I already was a violence nerd, and that's why I was called into these kind of high-stakes discussions. And this discussion was between a physician and his staff concerning a man whose child was gravely ill. And the father had been banned from visiting his own child in this hospital because he had been so aggressive, assaultive on staff. We understood that his child was gravely ill. I think it's also important to remind ourselves that particularly in that place where I was working at that time, it was a children's hospital, was filled with gravely ill children. And the vast majority of parents, and I've been that parent at the bedside of a gravely ill child, they don't insult and disrespect and, more importantly, touch without permission and physically assault the provider staff, But this father did. And after a cycle of trying to rein in behavior, when he became assaultive, he was banned from that particular hospital. So the issue was the patient was getting sicker, right? So he was asking permission, and his wife is asking permission to visit his child in the hospital again, and under what conditions that could be done. And of course, we wanted to do that. We wanted to make that happen. So I was going to meet with the parents and the physician and some of his staff members and mediate that. And we actually had a good outcome after that. Required a lot.
But Joel, just a little aside, but just a little so you can actually get banned from a hospital based on your behavior. That's a little bit of a warning to everybody.
Well, that's the thing. Hospitals have traditionally been very accepting of violence, and that's what this story is going to be about. And it's just like in any other relationship. You can call it a domestic violence relationship is often a good parallel. The more disrespect and aggression you accept, it often leads to violence. And if you're accepting of that violence, you're stuck in a cycle of it. And healthcare is really one of those kind of situations, one of those kinds of environments that is, if it's practiced as it has been traditionally, it's really very compatible with violence. And this story kind of illustrates that a little bit. So I've heard this said in hospitals where there were difficult visitors and such in hospitals, is that at the end of life, all bets are off, right? So they took those what they were saying was, yeah, we know this guy's been a problem, but it's the end of life, so we're just going to let him in and take our chances. Well, I was supervising this process. We didn't do that. We had scheduled visits. We had emergency contacts for when things got worse. There were supervised visits. So the hospital had to give a lot of resources and time and money to make sure these visits happened, but they were happy to do it with the understanding that they were going to be safe. There are hospitals where they wouldn't even consider banning a parent from visiting, or a husband or a wife from visiting their patient. But after some tragic incidents, that policy kind of changed, and you can wind up on that short list. Well, I'm sorry, but your husband's welcome here, but you're not. And it's unfortunate that we had to get to that point, and we like to work with families. But at some point, how much risk do we take? And do we expect our staff to take before we take action? And that's what we're talking about. The old all bets are off paradigm had to go.
But Joel, your point here is that some hospitals still have that attitude, and
they do. They let people, yeah. And it's unfortunate that it may take a tragic incident or a high nursing turnover. When you look at nursing job satisfaction surveys, you find some interesting kind of data that comes out of them. I've read some where I'm happy with my pay. I love my boss. Right. I like the work. But I just can't tolerate, the disrespect. I can't tolerate the aggression. I've been assaulted too many times, that kind of thing. Yeah. And there's very few professions where you would get something like that. It's sometimes in retail and other ones where the stakes aren't so high, where people just do move on. But these are people that have dedicated, an undergraduate degree, specialized nursing training, sometimes postgraduate degrees, to finally reach that point of burnout. I can't do this anymore. And the thing they point to very often, if not most often, is involved with these sorts of issues. Yep. And what I think we have to remind ourselves, though, is that most patients aren't disrespectful. They aren't aggressive. Sometimes they melt down when they're in crisis. And if we get good at dealing with that, that's to be expected. And we can actually deal with that in a very therapeutic manner. But the old yelling, cursing, threatening, you're not moving fast enough kind of mentality. On one hand, we might blame the victim. The nurses are, some of the feedback I've seen analyzing some of these incidents is the nurses were snotty, or they were too slow, or these sorts of complaints. And then these are value judgments.
With some message that they actually deserve it in some way.
Yeah, and that's usually the message in the eye of aggressor. Again, including in a domestic violence relationship, we tend to blame the victim.
Right. Yep.
So without digressing too much, in this particular meeting, while we were waiting for the parents to arrive, we're just making some small talk with the physician and some of his staff. And there was a nurse there who was an older nurse. It was a woman, very highly educated, had a master's degree in nursing. Having a discussion with her about her career, which is very long and accomplished. She'd worked in several different fields, surgery, cardiology, pediatric cardiology, things like this. And she was a very well-rounded, fiercely intelligent woman. And while we were talking and she was capping her career for me, I asked her, I said, have you experienced much physical aggression on the job? And she said, well, no, not really. It's not that big a deal. So I asked her, I said, you ever been spit on? And she said, well, yeah, that's happened. So I said, you ever been shoved by a patient? He goes, well, a couple times. You ever been slapped across the face? And she said, well, yeah, actually, that has happened. And you ever been kicked? Yes. Punched? Kicked? Hair pulled? Yes. Scratched? Yes. Well, what is she calling aggression?
Yep. And she just expected that. That was just part of the job.
Part of the job. And that part of the job mentality is part of the problem. Is where do we draw the line? And more importantly, how do we draw it?
Yep.
What is it about the clinical environment that maybe, it has to be more, and it's certainly part of the problem, because that's step one. Everybody who shows up doesn't want to be there. They walk through the door with several problems. The staff are overworked, right? And they work often overworked, and they work, a very physical and emotionally demanding job. It affects their family life. It affects their physical life, their psychiatric well-being, all those things. And then we put them together and we watch to see what kind of results we have. In no other profession, there are other professions, police work, corrections, things like that, social work, where we have to train people how to work in these relationships, how to set the social contract. Everyone's heard someone say this. Well, they need to teach her how to talk to people.
Yeah, big time. Yep.
And that's really what we're looking at. We're not telling people what to say. We're helping them understand how to say it and what things mean when they receive it, and how we can redirect it, how we can persuade people. We're in a profession where, we're not very good at persuading people to go with the program. And that's not only with treating us with dignity and respect, first by modeling that behavior, and then how to cooperate with therapy. That's a big problem, especially nowadays.
Well, and I think you're describing two ends of the spectrum, right? I mean, it's how do you communicate with people or talk to people such that this conflict, this aggression doesn't occur. Yeah. And there's obviously things you can do to minimize things escalating. And I know that was a lot of what was in your book. But then when things do escalate and somebody's being too aggressive and they're pinching or shoving or slapping or whatever, what do you do about it? Yeah. And I know one thing you've told me is that it's, frequently in healthcare, because obviously people that work in healthcare are empathetic and they care about their patients, and they get into those situations. And sometimes it's, well, can I get you some Jell-O or a sandwich, thinking that somehow is going to solve the problem.
Yeah, often we've been actually trained to reinforce those bad behaviors, and I've seen the cycle happen, where, a patient or a visitor, will lead outside of a door at a patient's room and yell down to nursing station, get your behind down here, and they'll come running.
Yeah, right? Exactly.
And when people are angry, give them we want to deal with their anger. We want to hear their problem, and we want to do service recovery for things that we do. But when people are being treated with disrespect and aggression, if we reward that, we'll see more of it.
Yeah,
and that's a cycle.
So in this case, you're the nurse that thought part of her job was to be abused. In so many words. And so where did it go from there?
Well, where it went from there is we met with the family, set limits on behavior, and just, kind of setting the social contract, helping, that family understand that we want his child to be able to visit with his father, And we just set up a schedule. We did some supervised visits. We put a way that he could have an emergency contact if something went bad during where he wasn't scheduled. So we were able to manage that with the understanding that what the expectations were, and he got it at that point. So he wasn't a perfect angel, but we were able to see to people's safety.
Well, and there was probably times where hopefully that nurse got the message and understood that there's times when, patient's gone a little too far, and you gotta set boundaries and
it opened the conversation, and then we were able to do some training with that staff that seemed to, the benefits of that is not only do we see a better relationship between patient and provider, but whether people like to admit it or not, if a healthcare provider, a nurse, any other type of provider is in fear of, or even doesn't like their patient, they're going to spend less time with them, right?
Yep.
Maybe even make more mistakes while they're worrying about watching their back. So it even affects patient outcomes. So if we're not good at this, it affects the bottom line because, people give you bad patient satisfaction surveys. That's something that they worry a lot about in hospitals, and nurses bring that up a lot. I can't tell someone, not to scream at me and call me names because they'll give me a bad satisfaction survey.
Exactly.
Well,
exactly.
If you let them abuse you, you think they're still going to give you a good one?
Exactly right.
That's just it. What we've tried, and kill them with kindness myth. That's something you hear a lot in healthcare. And just like I know I bring the parallel up, but it's really striking if you study both cycles of violence. If you look at a domestic violence relationship, and a friend of yours came and said, "Hey, I've been dating this guy, and he seemed like a nice guy, and he had a couple of beers, and he shoved me and called me the B word." You wouldn't tell her to kill him with kindness.
Exactly. Yep.
You'd say, get safe and get help. But that's the same advice that nurses give to each other day in and day out in every hospital, emergency room, a doctor's office across this country.
Yep.
They've heard it in their orientation training. They've heard it from their mentors, their supervisors. And it's a mantra that has contributed to the levels of violence in healthcare.
Yep. So I'm hearing two things here, Joel. So on one hand, right, we need to be aware that just because, you're in a hospital, that doesn't mean it's an environment where people should be allowed to abuse each other.
Right.
It's like any other work environment that people should treat each other with dignity, show them respect. You shouldn't have some expectation.
As a consumer, I especially get it. Healthcare is a high-stakes profession. Right?
Yep.
Trust me, at the local department store, the big box store, the customers always kill them with kindness. The same advice they're hearing day in and day out. But go in to buy your television at the big box store and call them a bunch of dirty names and yell at them and threaten them and see how fast you get kicked out or the police are called.
Exactly.
Right?
Yep.
I understand you can't take a cancer patient, or someone in the emergency room having a cardiac incident and throw them into the street. Not suggesting that.
Well, and that was what I was going to get at, Joel, is that there's boundaries, right? And in a retail environment, like you just said, you just kick them out and they don't get back in and everybody knows who they are and that's it. But in healthcare, you really don't have that opportunity. So on the other side of the equation, you need to set the boundary, but you need to do it in a way that works, which gets back to your strategies about, how do you do this? One is you got to be aware that you need to set boundaries. You can't let people abuse you. You can't get pushed and shoved and not do something about it. You don't want to be the victim and say, oh, let me get you some Jell-O or a sandwich or a cup of coffee or whatever.
They're happy.
So you need to deal with it. But the question is, how do you deal with it? Because you can obviously deal with it in a way that would make it way worse.
Yeah. Well, in healthcare, there's when it comes to the consumer, the client, the patient, there's kind of been an all or nothing mentality. Either we have to treat them and take whatever abuse they have to dole out, right? Or we have to cut them off, right? Send them to another hospital. I've been in those meetings. I've helped draft those discharge letters that say you're not welcome at this hospital. I've done them for entire hospital systems that were so big that you lost access to half the healthcare in that state.
Oh, wow.
Because, you just couldn't get that behavior under control. But what we're not good at is persuasion. And this is redirecting those behaviors so we set the social contract at the outcome. When they're walking in the door going, what's taking so effing long? We're saying, sir, I understand this is difficult. We have sicker patients coming in by ambulance through the back. Let me take a look and see if I can make you more comfortable for the time being. I'm going to ask you, please not to yell or curse. I'm going to treat you with respect, and I'm going to ask you to treat me with respect, that sort of thing. Setting that contract, because if we just absorb that behavior, it's encouraging more of it. And because it's a gateway behavior, it builds. Starts with the yelling, then goes to the threatening. And then if they're going to, demean us, yell at us, threaten us, then why not hit us? Again, just like a domestic violence relationship. But we don't have to be stuck in that cycle. We have to learn how to redirect and persuade. And persuasion, oddly enough, and I don't think it's just healthcare, because it's had a big impact on a lot of professions, such as law enforcement and corrections and education and other fields, is setting the social contract and using persuasion. Because if we were better at persuasion, then maybe almost 1/3 of family practice physicians and pediatricians wouldn't have admitted to prescribing antibiotics when they knew it was contraindicated, when they knew that it was harmful to the health of their patient and harmful to the public health. Almost 1 in 3 admitted to that, right?
Well, and Joel, as you know, my background is from years and years ago, but I was a hospital pharmacist, dealt with it all the time, and drove me crazy. Is why, or when this is every 10 years, it becomes the hot new thing.
Yeah, and you must have heard the reasons they gave for doing it.
Yeah, we knew that 40 years
ago. And you must
ago.
have heard the reason.
Oh, right? 40 years ago. Yeah. This is not a new. This is not a new problem.
Yeah, and what were the reasons that prescribers would give someone antibiotics even though they knew it was harmful? What were the reasons? Why?
Well, they don't want to deal with the conflict. It's whatever the output. They don't want the patient unhappy. They don't want the patient going somewhere else. They want to avoid the conflict. They don't have to deal with the issue. Yeah. And they go, it's just easier to write the prescription out and get the guy out of here.
And so do we got now, right? We know it's contributed to, I shouldn't say no, but I'm not a clinician. But the common wisdom would be this must have contributed to the superbugs and antibiotic resistant strains that we've seen crop up over the past few years. Is when you're over prescribing antibiotics, that's they say that's the main factor.
And Joel, as you know, and it's a topic for a whole nother podcast, but obviously it impacts the whole opiate crisis that's going on, right? I mean, it's just the same underlying issues happening where there's reasons why that doctor is prescribing another opiate prescription, and it has a lot to do with what we're talking about here.
Yeah, and I sympathize with that,
Yep. Oh, yeah.
And I understand, but, to help people understand, and I've had to do this, with physicians, even in the medical college where I did a little workshop, is helping them understand, how do you do persuasion? How do you explain to them that the antibiotic is harmful and this is why?
And yeah, exactly. Right? And doing it in a way that works. Right. But, and Joel, just so because you use the term, and it's a term that I certainly understand, but I wanted to spend just a minute on it, is use the term redirect first. And then now we're talking about persuasion. Yeah. Let's go back and just spend a minute on redirection, because as you know, that's one of our very specific tactics on how to deal with abuse.
Yeah.
And you gave an example of it, but I'm just going to take that example and break it apart a bit.
Okay.
Is that people want to, you were saying, whatever the guy's on you about whatever. And you're going, well, first, let me acknowledge that I heard you. I understand where you're coming from. And I can't remember the exact words you did, but it certainly, as I was listening, I go, I feel good about that. This guy's listening. He's, concerned about my situation. He's acknowledging my issue here. However, then you quickly went to, but at the end of the day here, we still have to get back to the point and the issue. I'm not going to let you just continue to abuse me here. I'm willing to acknowledge your concern and your, whatever anger, whatever it is, but I still have a job to do, and we still got to get back and deal with whatever we're dealing with.
Yeah.
So, the whole redirection has two steps, right? Acknowledge their concern, and there's a variety of ways to do that. And then let's get back to the issue to make sure they know you're serious.
Yeah. The message is, I hear you and I want to help and I'm doing the best I can for you right now.
Yep.
And then, redirecting them, to what's important. However,
exactly.
This has to be a safe and comfortable environment for all patients. Right? Yeah. And that's the expectation. The behavior you allow is the behavior you get, and there's lots of parallels to that outside of healthcare, like a cell phone in a movie theater. Took a while for everybody to get that. Working in a hospital, a few years back, and I'm sure most people can relate to this, especially if you worked in hospitals. When I first worked in a hospital, there was a smoking room in the hospital. One for,
I remember that.
Right.
Yep.
And there was one for staff and maybe one for patients. And then sometimes they were just combined. It was a normal, social behavior at the time.
Yep.
Then a few years later, they moved them outside. Right. And then,
and Joel, you probably don't remember, but I was actually involved in, the amount of money the hospital I was in was in Philadelphia, but amount of money they spent to put in the air ducts and stuff to make sure the smoke got out of the room and all that, just so somebody could smoke. It's like,
I can
really
imagine, and air filtration systems and all this.
It was I had a lot of money just so somebody could smoke in a room inside the hospital. Yeah. Well, those days are past.
They're past.
Yeah.
But the point I'm trying to get to is, first, they went from inside the hospital to a smoking booth outside the hospital to eliminating, to banning smoking on campus, period. And probably the pushback we heard most often, right, because I was involved in some of these projects, was patients will never accept this. You can't tell somebody whose, wife is sick in the hospital or they're having a baby or whatever, they can't go outside and smoke, right? Can't do it. And it'll never happen. And within a couple of short years, it did happen.
Yep.
Right. And the place didn't fall down like everyone predicted. Right.
Right. Right.
When they first banned smoking, in prisons and jails, they said the prisoners will riot. It'll be a bloodbath if you ban it. There was no bloodbath. Right. Helping people understand that you can affect, people will adapt to the environment that they're in. If the environment that you're in is accepting of a certain behavior, guess what happens? You're going to get it. You're going to get the behavior you're accepting of, right? And then when there's lots of things that hospitals can do to do effective persuasion. Persuasion is helping people understand the context. Right, and their behavior, right, and the expectations. Yep. And then if that doesn't work, it's offering them choices. This is where they get, a good choice versus a bad choice and empowering them to make that choice. In the vast majority of cases, they will take the good choice, right? Even though people say over and over again, hey, if you tell someone not to do this or to do that, they'll just, tell you to jump off a pier. But most of them, and even if you ask them, like say in a training, have any of you ever asked somebody to stop doing something inappropriate? Most of them will say, and the person responded with, I'm sorry, I didn't mean that. I'm just upset, right? Most of them in that class will say, well, yeah, that's happened to me. I've had that head nod. Well, all of those that are saying, yeah, nodding their head, yes, are exploding another, very destructive myth that's in healthcare that contributes to all this violence. And that myth is that if you say something, it'll make it worse. We have to say something when these things come up, because if we don't, the nonverbal message of silence is it's okay to abuse me. It's okay to disturb other patients. It's okay to threaten people.
Yep.
And that's something that we're really not good at in healthcare. And it's because of the high stakes thing, and I get that. But there are things that we can do to persuade people. There are bad options for people. We have to be willing to execute those options. And that's something we've been not really good at in healthcare. Imagine you were cussing out a nurse or sexually harassing a nurse or something like that, which is a common complaint in hospitals. Being flirty, being inappropriate. All the excuses came from the family. Oh, that's just Uncle Jim. That's just how he is. He's harmless. He doesn't mean anything by it. And so our message to the nursing staff, the female nursing staff then is, well, you have to accept this. He's just being Uncle Jim. I know it's inappropriate, but he's sick and he has to be here. Imagine if you're able to say to that family, well, we know that's Uncle Jim, but that's not allowed here. So if Uncle Jim has to get his sexual harassing behavior under control now, or he's going to lose his visitation privileges. Period.
But Joel, as you know, and I've been asking this question for the last 10 years since we started the company. But if you ask people, what do you do if somebody's in your face and they're abusing you, yelling at you, screaming, cussing, whatever? Most people just stare at you going, I don't know, right? And then what happens is they can make it worse by getting too assertive, too aggressive, whatever, and acting out, and because they don't know how to respond. And then I think the bigger issue is the second one, which you ask people, you ask somebody to do something, they say, I'm not going to do it. Then what do you do?
Well,
right? And
yeah.
It's rare that I find anybody that goes, oh yeah, well, I would go through this little process. And as you're describing, there's a very specific 3-step process that most of the time will get people to go along with the program.
Well, first you have to train people. I get very passionate about this subject, Al, so I can get pretty animated. And, all behavior is equalized. So if someone's being aggressive, we should never be aggressive in return. We have to maintain our professional language. We have to model the behavior we want to see. If they're yelling, we want to get quieter. If they're crowding, we want to step back. Many of the physical alternatives and things that we train, as you know, are the one-handed stop sign, the two-handed stop sign, the emergency timeout, proxemics, maintaining our professional distance that maintains safety, and that the first responder philosophy is when are we in danger and shouldn't have this conversation right now, and when do we need to contact the right people to support us. It's all part of a system that people have to be trained to do. And where we've seen it done, where hospitals have dedicated themselves to this training, we've seen some impacts that are positive, measures that are even extreme, and the reductions in assaults on staff, improvements on their morale, positive effects on patient satisfaction surveys. It's just, this is such an intimate relationship between provider and patient. We have to understand how to communicate and how to set limits and how to persuade, right? And know when to get safe, right?
Well, and you said it back early in our discussion here, is that people just aren't trained on this. It's like, when were you ever trained on how to talk to people? Other than, some good manners stuff. But this is, and Joel, I think here's what I'd like to do is, I think this has been a great discussion to identify the problem. I think we figured out that there's things you can do, that you can't just let things happen. You can't just ignore it and assume that it's part of the job. You need to take action, but you need to take action in a defined way, or you might make it worse, right?
Yeah.
And so why don't we why don't we kind of wrap this up, and maybe the next time we're on, let's dive a little further into this persuasion approach about, how do you take somebody that says, I'm not doing this, and what do you do to get them to go with the program without, calling security and asking the guy to get taken out of the building?
Yeah, that's what we do, Al. You described it perfectly. We go to 0 or 60. Exactly. Nothing in between. Yeah. 0 or 60. Give in or call security. And the paradigm has to change. And where we've changed it, we've seen really positive results.
Well, as you know, one of our clients, you just heard this last week, was they have a outside security team, which is very common. One of these private security companies that deals with security, and then internally they have people that have actually been trained by us, and it's just a huge problem because the security person shows up and doesn't know how to deal with that patient appropriately, and then things get worse, and so they're actually saying, we got to find a way to bring all our security team inside so we can train them, and so everybody's dealing with people in a consistent manner.
Yeah. And like I always say, Al, inconsistency is the enemy of peace, and I've seen it go both ways. I've seen it where the security staff has been trained, right?
Yep.
And medical staff shows up, and then it goes south. Right? I've seen it like this, where the medical staff is well trained, and the security staff shows up, and it goes south because the lack of consistency in approach, the lack of level of competency in their training and supervision, where you see, most violent incidents can be traced to some form of inconsistency. Yeah.
Yep. I was pretty sure when I said consistency, you would. That's one of your more famous quotes, right? Inconsistency is the enemy of peace, and we've learned it's so true.
Yeah. Well, I had lots of bumps and bruises to learn that over the years, though.
Yeah. Well, maybe the next time when we talk about persuasion, I think you have a great story about that, of both about the impact of being consistent, and then I can remember another one about what can happen if you're inconsistent. Yeah. So let's deal with that the next time. I appreciate you spending the time. It's always fun talking to you, Joel. I always learn something new, and we'll do this again.
Thanks, Al. It was fun. Looking forward to the next one.
Yep. Okay. Take care.
Okay, bye.
Well, that wraps up another episode of Competence in Conflict. I hope you enjoyed my discussion with Joel Lashley and got great value from hearing from Joel on how to create environments of care that are incompatible with violence. In the next episode, I'm going to be talking to another book author, Dave Young. He's a co-founder of Vistelar, and he's the author of the book, How to Defend Your Family and Home, Outsmart an Invader, Secure Your Home, Prevent a Burglary, and Protect Your Loved Ones from Any Threat. I think you're really going to enjoy this interview. In the meantime, if you want more expert advice on how to prevent and better manage conflict, subscribe to this podcast at Apple Podcasts, Stitcher, or wherever you get your podcasts. And if you like this episode, please write us a review. Also, visit Vistelar.com/blog to get notes for this show, share your comments, and access additional conflict management resources. Take care and stay safe.